Okay, let's go ahead and get started. We're going to take a look at the respiratory system today, at least from the anatomical perspective of it. And that way, when we get into lecture, we'll be covering the physiology of the system. So anybody have any questions on anything? Okay, good. Well, whatever. So let's go, here we go. Get this down. Yeah. You know, we're running out of lab content. We're going to finish up pretty soon. So just I know you're all going to be disappointed. So okay, AP2 Lab Respiration. So the anatomy of the respiratory system. We have two sections to the anatomy system, respiratory system. We have the upper respiratory tract and the lower respiratory system. The upper respiratory consists of the nose and the nasal cavity, and the sinuses and the pharynx. The pharynx is the tube that connects the nasal cavity to the oral cavity to our larynx, our voice box. And so even though we call it the pharynx, it is, it's the back of our nasal cavity, or it's the back of our mouth. It's our throat, if you will. So we have the nasal cavity, the nose and the nasal cavity, the sinuses, which we all know are located, in the frontal bone, and then we have the pharynx. The lower respiratory system consists of the yes, hello. That's okay.
I was just going to bring this file so you can tell your
Oh,
students.
great, thank you. Thank you. If you want to, if you'd like to stay and be a specimen. Okay.
Thank you for the invitation.
Well, I just, I'm always, I'm a giver. So, okay. Yes, registration for summer and fall starts on Monday. And if you are interested in taking any of those classes or need to be cleared to register, let me know. All I need is your W number, and I can clear you and remove that registration hold. That's all. If that's the only hold you have, I can clear that. I don't get to do much, but I can do that. So, and if you have any questions on what classes to take, and you can't get a hold of your permanent advisor, come and see me. I'll be glad to answer. I haven't advised anybody for over a year, so who knows what I may put you in. So anyway, so lower respiratory system, the larynx. It is what we refer to as our voice box. It is actually where the digestive system and the respiratory system divide, where we send food down the esophagus and air down towards the trachea. The trachea is a ridged tube that extends down to the lungs. And the trachea branches into the bronchi, and the bronchi subdivide into the bronchioles, smaller tubes that the bronchi penetrate the lungs at the hilus. And then the lungs are made up of millions of sacs of simple squamous epithelial cells forming structures called alveoli, and the alveoli are the site of gas exchange. So that's our respiratory system anatomy. Our nose is the only part of the respiratory system that we can see, believe it or not. Everything else is internal. The nose has a lot of functions for us. It is the beginning of our airway. It's designed to bring air in, to clean it. Those nose hairs have a reason. They're to trap dust and dirt particles. There is mucus lining the inside of the nose and the nasal cavity. that is designed to humidify the air. It's also going to warm the air up. It plus dust and dirt and debris get trapped in that mucus, so we're going to clean the air. We have the air that eventually gets down to our lungs could be considered sterile because we've taken out everything that's in there that could be harmful. The nasal cavity functions as a sound chamber for us. If you think about it, if you've ever been congested, sinus infection or whatever, and you try and talk with your nasal cavity clogged, you sound funny. We don't even sound the same if you put your fingers on your mastoid process. You sound different to yourself than when you don't. Every time I do that in AP1 and I have my fingers there and I take my fingers away, it sounds different, just that much. So, plus, in addition to all that air cleaning and sound chamber, it's where our olfactory receptors are located on the inside anterior surface of the nasal cavity. This is where we detect odors. Now, the sense, as I've been telling my AP1s, sensory receptors don't know what they're responding to. They're just responding. A sensory receptor for odors will be stimulated by an odor. It won't be stimulated by light or touch or pressure or pain. But all it's going to do is generate an action potential. And that's what they do. They respond to molecules landing on them that will trigger the production of an action potential. Now we have the external nose and the nasal cavity proper. There's our nasal cavity. Now I like this picture for a couple of reasons. It does show you the three parts of the upper respiratory system. You can see the nasal cavity right up here. There's the nose. The nostrils are right here. This is the pharynx. This is really a tube that runs from the larynx up to the nasal cavity. We call this the nasopharynx up here. We call this the oropharynx here. And down here, we just call it the pharynx. Or maybe we might want to call it the laryngopharynx if we're going to be precise. But you can see that this tube is open to all three areas, which is why an infection in our nasal cavity very quickly spreads to our oral cavity and maybe even down into our lower respiratory system because it's all connected.
How does it go to your ears? Or does it?
Oh, I'm glad you asked. See that little opening right there? That's the opening to the what we used to call the Eustachian tubes.
Okay.
We still call them the Eustachian tubes, but there's a laryngotympanic or some other name that they've been using in the later books. But that's the opening to the Eustachian tubes, because those tubes are designed to equalize air pressure, but they're also a passageway for infection to go to the ears.
So when kids get tubes in their ears, is that where they're placed?
Right, because the opening's already there, but it allows the equalization of pressure. Because I would imagine that in a child, if that pressure doesn't change, it's probably pretty painful.
Yeah, my daughter's had 5 set of tubes.
Yeah,
Yeah. So I was wondering because they say in my son he has really bad allergies, so his drainage in his ear.
Oh yeah. You get a lot of pressure. You get a lot of pressure in there, and it can be very painful. And most of us, we've all experienced when our ears pop. If you've ever flown, you know that there's that point where it finally popped.
Yeah.
And that's fine. Around here, it's depending on if you drive up in the mountains somewhere. It happens all the time. You drive to Gatlinburg and your ears might pop, from down here. So, but this is the upper respiratory. Okay.
And our bodies right there so me screaming and it's like someone firecracker in my ear to try to unblock the tubes because they would get blocked.
You live out in Mooresville?
No, but I have friends that live out there.
Do you?
So,
Yeah.
So I don't know where Shagbark is, so.
You know where the subway is and the gas station? It's like a few roads ahead.
Oh, okay, okay, got you. So now I know where it is. I think they're further out, so. Okay, so we have the nasal cavity. There's three ridges that you see in here. Those are very important structures. They're called conchae. And I'll have more pictures here in a second. But what they do is when air comes in through the nostrils, they create turbulence. The air swirls around those three ridges there. So it gives the air more time to be exposed to the sticky mucus to drop off any dust and dirt. It allows the air to be warmed up and moistened. So what's leaving the nasal cavity and going down the oropharynx down towards eventually to the larynx is clean air. Now that whole cavity is also lined, except where we have the olfactory epithelial cells, is also lined with pseudostratified ciliated columnar, because that mucus has to be brought, the mucus that traps the crud has to be brought down to the stomach to be destroyed. So, okay. So the nasal cavity, has a septum down the middle. There is an opening where we turn in from the cavity to the nasopharynx. That opening, let me go back. Nasal cavity becomes a nasopharynx back here. Again, that's what the opening to the Eustachian tube. And then we have the ethmoid bone and the sphenoid bones forming the roof of the nasal cavity, and the floor is the hard palate. So the roof of the mouth is actually the floor of the nasal cavity. You can see that again back here. There's our palatine process of the maxilla. There's our palatine bone. This is the roof of the mouth, but that is the floor of the nasal cavity right there. Now this little thing back here is the soft palate. This is called the hard palate. This is called the soft palate. And the little dangly thing is called the uvula, the thing that you can see hanging down in the back of your throat. So, and then of course the nasopharynx is continuous with the oropharynx. Let's see, now let's go on here. We have hairs lining the nasal cavity at the nostrils. There's a reason for that, to filter out air, filter out large particles. At the top of the nasal cavity, we have the olfactory epithelial cells, and they're designed to be stimulated by molecules. The ability to smell depends on a molecule of some odorant, a chemical that causes an odor, landing on one of these olfactory epithelial cells. But they have to be dissolved in water first. So the olfactory epithelium is contained within this mucus lining, because the olfactory mucosa secretes mucus. And so that the entire nasal cavity is lined with mucus. It's all wet and slimy. And the odor, the molecules dissolve in the mucus and then are transferred to the epithelial cells. So everything has to be dissolved in water. And we'll see the same arrangement in our lungs. To get oxygen to go across the alveoli into the capillaries, there's a lining of mucus on the inside of the alveoli, and oxygen has to dissolve into that fluid so it can diffuse easier. So we use there's a lot of water, mucus involved here. Anyway, if we don't have the areas where we don't have the olfactory epithelial cells, it's all going to be mucous membrane, pseudostratified ciliated columnar epithelial cells with lots of goblet cells to secrete lots of mucus, to clean the air, warm the air, and moisten the air. So that is the rest of the mucosal lining here. And so here's what it looks like. There's a bunch of pseudostratified ciliated columnar epithelial cells here. There's the cilia right there. These are goblet cells. Goblet cells secrete mucus. That's what they do. and they're adjacent to the columnar epithelial cells. And so the mucus has, it has the job of moistening the air, moistening the air and cleaning up the air. So, because particles get stuck in the mucus. And then the cilia are going to push that mucus down into the pharynx, and we're eventually going to find its way into our esophagus where we swallow it. Just like the mucus that comes up the airway. I probably mentioned this way back in the beginning of AP1 Lab. The pseudostratified cells line our airway and do the same purpose. They moisten the air and clean the air that we inhale. And then the cilia bring the mucus up into our throat. We swallow it and destroy it in our stomach. We swallow about a pint a day of mucus that we're not aware of. I'm glad we aren't aware of it. It would probably be, if we knew what we were doing, we'd probably feel it was unpleasant. I'll just say it that way. So, okay, the concave, those ridges there are designed for two reasons. The big reason is to create turbulence in the nasal cavity. Because the more the air moves around, the more it's going to be exposed to mucus, and it's going to warm up, and it's going to get wet, and it's going to get clean. Because warm, moist air does a better job of containing oxygen than does cold, dry air. So we have the turbulence, but we also increase the surface area of the entire cavity. So we have a greater chance, not just of pushing a bunch of air around the concave, but also making sure they come in contact with the mucus and get cleaned and get wet. So they also, since since we have mucous membrane there, they're gonna get warm. I forgot to say warm, but I'll say it again here. They're going to warm up the air, they're going to filter the air, and they're going to moisten it. So now we have clean, warm, moist air. When we breathe out, we get the heat back, we get the moisture back. If we breathe out through our nose, we probably do more than we realize. Okay.
I have a question for you.
Yes.
If that's the case, like what we need to breathe is hot, moist air. How come Tennessee feels like it's so much easier to breathe than Middle Georgia? The air is drier and cooler up here and hotter and moister down there.
We are probably at a slightly higher elevation. So the air pressure is a little bit less. Here the air is less dense to us. I mean, granted, we're only about 1,000 feet above sea level here. I don't know what Georgia is, but it's probably, probably like 100. So there you have, the air is probably as dense as it can be. So it makes it more difficult. The denser the air, the molecules are going to get in the way of each other. They're going to be warm, they're going to be moist, but there's going to be a lot more of them, and it just may feel oppressive. Here the air is a little bit cooler, it's still warmed up and still clean, but if we were to go up 5,000 feet, it would feel great. Higher elevations, as long as we're still within our 80% oxygen levels, higher elevations do better for us. So of course, we all know what summertime around here can be like too. So yeah, and that has to do with the amount of moisture we're putting in the air, and quality of air too. We're in as I say, a perfect inversion area because of the way the valley is located with the mountains on either side. So, but some days are pretty good. So anyway, here's what our concave looked like in our cadaver. You can see the three concave here on this photograph. You can see up here are the olfactory epithelial cells, epithelial layers. Everything else is covered in mucus. We can see the opening here for the pharyngeotympanic auditory or Eustachian tube, pharyngotympanic auditory. I don't know why they have to change the name to it.
So it was before it was called
the Eustachian tube.
Okay.
Yeah, that's the opening for that right there, and it goes straight to the into the middle ear to equalize the air pressure. It comes out behind the tympanic membrane so that when the pressure it relieves the pressure in the middle ear, because the nose is open to the outside, and that tube allows the middle ear to equalize pressure. So, because the outer ear, the outside of the tympanic membrane, is the same as the air pressure is the same as this for everybody, wherever we are right here. Behind the tympanic membrane, behind the eardrum, in the middle ear where the bones are, the ossicles, we have to get our ears to pop because they're not. It's not as easy to equalize the pressure there. So anyway, now, and of course, there's our nasal hairs right there, they do have a purpose. They are designed to filter out large particles. We find that nasal hairs continue to grow as we age and become more and more prominent in older people. You may see an 80-year-old with, a large growth of nasal hairs coming out there. It happens. It's nothing, it just, that's what they do. Yeah, it's a part of life. Thank you very much. Okay, now, one of the problems we have with our nose is that we get sick. We get infections. Rhinitis is a sort of a catch-all name. The term rhino refers to the nose. Rhinoplasty is a term for plastic surgery of the nose, a nose job, if you will. Rhinovirus is a virus that infects the nasal cavity. So rhinitis is any kind of inflammation that's taking place here. And of course, because these areas are continuous with each other from the trachea all the way to the nasopharynx, to the nasal cavity, an infection can spread very easily. It can also move into the sinuses. Now, the sinuses are a series of cavities within the bone, along here in the frontal bone, and they function to lower the weight of the skull. They function to give you a resonance chamber for speech. If we had solid bone along in here, we would have to have much more stronger muscles to hold our heads up. In fact, you can see it. Let me bring this over and I'll put it on the camera too. These are the sinuses, the sinus cavities we see here. Let me put it on the camera.
So when you have the sinus,
That's why you have pain right in this area here. Okay, now, here we go. These are the location of the sinuses right here in the bone above the nasal cavity, in the area of the frontal bone above the orbit and on either side of the nasal cavity. And of course, they can become inflamed. They can become filled with mucus, and they provide a nice, warm, dark, moist environment for bacteria to grow. And we have the ubiquitous sinus infection. This is where it's affecting us. This is because this is why we get pain. And you go to your healthcare provider's office and they start pressing against your sinuses and they say, "Does that hurt?" And you say, "Yes, it hurts." Then it's likely a sinus infection. And even think about the function as a resonance chamber. Just putting my fingers across here, I can hear a change in to me, my voice sounds different.
Yeah.
I can hear a difference just by doing this. So think about how our voice changes when we get an infection.
That's why you sound like all that.
Oh yeah, you sound very strange. We all sound very strange when that occurs. Let's see if So sinusitis is the condition. The sinuses are inflamed. It's sort of a catch-all term. If we're lucky, it's bacterial, so we can get it treated right away. If we're not lucky, it's viral, and it'll take 10 days to run its course. Hopefully it's bacterial and it responds to antibiotics. Now let's move on. The pharynx, the tube that connects the nasopharynx, the oropharynx, and the laryngopharynx. The nasopharynx contains, is lined by what we call the respiratory epithelial cells. Only the olfactory epithelial detect odors. Respiratory epithelial are just those ciliated columnar epithelial cells, pseudostratified. We do have a set of tonsils in the nasopharynx called the pharyngeal tonsils. The tonsils are part of our immune system. They are sacrificial. They are designed to become infected so we can trigger an immune response. So our pharyngeal tonsils and the palatine tonsils in the oropharynx are all designed, they form a ring around the opening to the trachea, and they are designed to sacrificially become infected by a pathogen, triggering the immune response to fight the infection. So these tonsils, our tonsils have a reason. Now, pharyngeal tonsils are also called adenoids. Generally, we refer to them as adenoids when they're inflamed or when they're being removed. The same with the palatine tonsils that we see on either side of the uvula in our mouth.
So why do they remove your tonsils and adenoids if they serve as like?
Well, there's two schools of thought on that. In the 1940s and 1950s, everybody was having their tonsils out. Once you got into the 60s, then the conventional thinking went back the other way. Nobody had their tonsils out. In the 70s, it sort of went back to taking them out again. Now it's sort of hit or miss. Some people say take them out, some say don't. If you have a patient, especially a child, that develops lots of respiratory tract infections, the tonsils are always getting inflamed. In cases like that, sometimes it's advisable to have the tonsils taken out simply because they're always catching these pathogens. And if you remove them, then it's more likely for them to not develop an infection. So it's one of those, well, we can take them out or we can leave them in, by 6 or 7 years of age, children have been exposed to a lot of the same types of oral, pathogens that are going to cause an upper respiratory infection. They're all pretty much the same, and they're still going to develop an immune response, despite the fact. But they may be less prone to develop an infection and become sick because they don't have the tonsils and adenoids there.
Yeah,
And
adenoids grow back. Correct.
they shouldn't.
My daughter's had hers taken out twice.
Really? Okay.
Yes.
Well, there's.
And he said they grew back. I'm like, how they grow back? I'm like, took them out.
Yeah, well, I have never heard that, but I don't.
She's had them done twice.
I don't doubt that because our bodies do strange things.
But they're not supposed to.
I've never heard of them growing back, but that doesn't mean it can't, I used to tell people, say that if you were vaccinated against chickenpox or you had chickenpox, you would never get it again. And then I've had people tell me, well, I had it 3 times,
Yeah.
So I've learned not to say that,
Yeah.
So our bodies they'll do strange things. So because it really it's just designed to trap, the design of the tonsil is to trap bacteria in cavities within the tonsil. And so it's a very simple structure. If not all of it was removed, then it could grow back.
Your tonsils good?
Well, the adenoids,
Oh, I thought you were about your tonsils.
No, the adenoids, remember, they're considered tonsils.
Oh, okay.
But if they're not, if all the tissue isn't removed, maybe there's a base for, if all the cells aren't removed, maybe there's a base for it to grow back.
Okay,
That would explain why
why they grew back.
they would grow back,
Hmm.
Now, the oropharynx, the oral cavity, stratified squamous. Why? Because we eat things and we drink things and we wear away cells. You don't want to have simple squamous cells there because it would damage the underlying tissue. So we have lots of stratified squamous cells, lots and lots and lots of dead layers, followed by lots of living layers. And we also find the palatine tonsils there, the large tonsils on either side of your uvula. And then we get down below the oropharynx into the laryngopharynx, and we go all the way down to the larynx itself, where the trachea and the esophagus separate out. So now, and there's our nasopharynx back up here. There is our oropharynx in here. Our laryngopharynx is here. This is the opening for the airway, and this is the trachea running down here. And this is the esophagus right behind it. This tube is the esophagus. And then you can see there's our spinal column right here. And there is our spinal cord right along here behind that. So, so you can see at the laryngopharynx, we split then and have the trachea going one side and the esophagus going the other way. And this opening will automatically close by reflex whenever we swallow, so that we don't aspirate fluid or solids into our airway and into our lungs. So, okay. So the nasopharynx leads into it's the nasal cavity. When we swallow, our soft palate and our uvula actually flip up. The soft palate is this structure right here, and the uvula, the dangly thing, is right there. When we swallow, this structure, oops, there we go. This structure right here flips up and closes off the nasopharynx. We're not supposed to, when we swallow, send something out our nose, no matter how funny it looks. We all know people that do things like that can, we all knew somebody in grade school that would shoot milk out their nose. You didn't?
Yeah, no, I know. I'm
Yeah,
just like,
okay, because it is a continuous structure.
Join the same as I have to go.
Okay. Okay. Now, so that's the purpose of the uvula, to help close off the nasal cavity. Now, we have the adenoids, the pharyngeal tonsils, in the back wall of the nasal cavity. And of course, we have the auditory tubes there to equalize pressure in the middle ear. The oropharynx is from the soft palate to the epiglottis. The epiglottis is the opening into that controls access to the trachea. The oropharynx is a common tube for both food and air. And you can see there's the oropharynx. Air comes down this way, food comes down this way. They share the oropharynx, they share that tube. And then, down here at the laryngopharynx is where we divide it. Every time we swallow, this little flap here called the epiglottis, right above the arrow, it's not marked yet, but this little flap flips over and closes this structure here and allows food to come down into the esophagus. Every time we take a breath, this thing flips up and air can go down this way. And to keep air from going into our stomach, this right here is what's called the esophageal sphincter. It's closed. It only opens up when we swallow. So two things happen when we swallow. The epiglottis, this little flap right there, flips down and the esophageal sphincter opens up. Actually, three things, because the uvula has to flip up and close off the nasal cavity. So a lot of flipping going on inside our mouth. So, okay. Now, the oropharynx, already said all that. Oh, we have another set of tonsils. We have the lingual tonsils that are underneath the tongue. So you have the palatines on either side of the uvula and the lingual tonsils underneath the tongue. So we have three sets. And then we have the laryngopharynx. This is, allows air to get down to the larynx. And we have the esophagus. Problems, adenoids. Adenoids get infected. We know they do. That's what they're designed to do. Adenoids and tonsils get infected. And the problem with that is we end up breathing a lot through our mouth. And so we have, we're not cleaning our air. Of course, if your tonsils and adenoids are infected and swollen, the last thing you're worried about is breathing through your mouth, because any other way or swallowing hurts. We've all had that experience. The adenoids and the tonsils, though, will get in the way of breathing. They'll make it more difficult to breathe. They will press against the airways. So it'll be more difficult to sleep. You will sound funny. You'll talk funny because of this enlargement in your throat. And one of the things that you'll see with your patients is that when the palatine tonsils are inflamed and they're swollen, it creates I won't say unnatural, but an inaccurate representation of just how swollen they are, because your patient may feel like they can barely swallow or they can barely breathe because they feel the tonsils are swollen up to the size of like a grapefruit or something, and they're like, I can't breathe, or I can't talk. Well, yes, they'll be inflamed and they'll hurt, and may even have sores on them or ulcers, but they're not going to close. They are usually not anywhere near close enough to affect the airway, even though it will feel like it. We have a disproportionate sense of enlargement because we can't tell how big they are. We can't see unless we look in a mirror, and so it hurts to swallow, and we feel swollen, and we feel like we're having a hard time breathing, and it's very easy to get concerned, especially in small children. So, okay, and we'll get more into that when we talk about the immune system and the lymphatic system. Lower respiratory system, the larynx, the trachea, the bronchi, and the lungs. We have the respiratory zone and the conducting zone. The respiratory zone is where gas exchange actually takes place. That's down in the lungs where we have alveoli. The conducting zone is everything else. Everything that brings air, gases down to the alveoli. The nasal cavity, the nasopharynx, the oropharynx, the larynx, the trachea, all that, the bronchi, those are all part of the conducting zone. We don't get to the respiratory zone until we're at the very end of the bronchi. When we get down to the alveoli structure, the whole purpose of the lungs most of the respiratory structures are designed to get the gases to the alveoli. Okay. The larynx is our voice box. It has three purposes: to maintain an airway, a patent airway, an airway that is constantly available, constantly open. The larynx has the responsibility of sending air down the trachea and food into the esophagus. And it also produces sound, voice production. Our vocal cords, our vocal folds are located in the larynx. So this is what a larynx looks like. This is a pretty bad illustration here. It doesn't show you a whole lot of anything, but it is in this area. If you want to know where your larynx is, if you place your finger on your throat and you feel a little dimple, a little depression right above your collar button, that is this dimple right here. We have the cricothyroid ligament. So if you want to know where things are, you have a very large thyroid cartilage directly above that. So this, if you find that dimple, you can feel a large piece of cartilage up here. That's the thyroid cartilage. A little further up, you might even feel your hyoid bone. It's the only bone in our body that's not attached to another bone. Above that is the epiglottis that closes the opening to the vocal cords. Below that dimple, we have one more ligament, and then we lead one more cartilage, and then we lead into the trachea right there. So just by finding that little dimple there, and that dimple where the cricothyroid ligaments located is usually where we have tracheotomies taking place, where we can make an incision in the throat to open directly into the airway. So if a person's going to have a tracheotomy so they can breathe, perhaps they're having surgery, perhaps they have an obstruction somewhere, the incision is usually made right in that little dimple. So, yeah. So the larynx has the voice bone. It has the hyoid bone. It is made up of 9 pieces of cartilage. We have the epiglottis. We have the thyroid cartilage, which is where we have the location of the thyroid gland. We have the cricoid cartilage, and we have 3 pairs of small cartilages, and we have the vocal cords or vocal folds. So now the epiglottis is the first thing we see here in the larynx, not the larynx, the larynx. It is elastic, and it will cover the opening to the trachea when we swallow. And it looks like this. This is the epiglottis. This is a cow epiglottis, by the way. There's the opening down to the trachea of the cow. This is what's left of the trachea here. They only gave us the lungs and the trachea of the cow. But this is the epiglottis. The epiglottis will flip over. This structure here will flip over and close that opening. In humans, this is the epiglottis where the blue arrow is. There is the opening that's going to cover. That's what we call the glottis. This opening is called the glottis. So this will flip over and close that opening so that nothing we swallow will go down this way. Now on this model, I've got right here. I lost my brain. Let's see if I can get this to fit on the screen. This is the first time I've gotten to use these really expensive models. So let's see if I can get this to. Okay, now this is probably not going to be big enough. Let me put on the other camera. Okay, now. You can do it. There we go. Now, what we're looking at here is a model of the larynx. What you see right here is the hyoid bone. The hyoid bone sits directly at the top of the larynx. Again, it's the only bone in our body that is not connected to any other bone. And we see here is the thyroid cartilage. here is the cricoid cartilage, where the dimple I was telling you about, you can feel in your own throat. And then these rings of cartilage here are forming the trachea, or surrounding the trachea. This is the first 5 or 6 rings of the trachea itself, our airway. Now, if we look inside here, we can see this structure here that flips up, flips back and forth. There we go. This thing is the epiglottis, and it works, it's sort of very much like that, you know. Now, when we swallow, this thing flips down and covers the airway right in there. There's the glottis down there. When we take a breath, then this is in the up position and the glottis is exposed. So, and you know, these also represent, if you look carefully down inside there, you probably won't be able to see them. But we have the vocal cords are down inside this. So anyway, this is our, not the scale, trachea, broken larynx, oops, and feel free to pull the string on there.
Don't break it.
Yeah, see, it closes the, it opens and closes the glottis. So, okay. That's what the epiglottis does. The epiglottis flips over. This is what it looks like for real. You know, the structure of the cow structure and our structure are pretty close as far as what it does. We see where it's located right here, right above the opening to the glottis here. Now, when we swallow, we see, you can see if you look carefully, come on, you can do it. There we go. When we swallow, the epiglottis is this structure right here. That little line sticking. Notice how the epiglottis flips down to block. There's the glottis right there, that dark spot. Notice how the epiglottis flips over to block the glottis, and whatever we're swallowing is directed down the esophagus. The esophagus is here behind the trachea. So we, you know, the only time that we aspirate fluid or food into our airway is if we leave the epiglottis open, and that happens. We're talking, we're laughing, we're chewing. You know, we've all, you know, choked on something. You know, it's happened to all of us. So, and it's because we didn't get the epiglottis closed in time. So now, so there's our epiglottis. You know, there's our hyoid bone in the front. We're looking at this from the posterior surface. It's almost like the model. There's the epiglottis. There's the thyroid cartilage, the cricoid cartilage. Goes all the way around, and there's the opening for the glottis right there. And the role of the epiglottis is to flip down. Now, what's the hyoid bone doing there? It's protecting everything. It's attached to some membranes on each end of the hyoid bone, but it's designed to protect everything. Okay. Oh, what about when you vomit? Oh, good point. Again, when, you know, even though it is, as we like to say, reverse peristalsis, you know, which is a nice way of saying it, the action of food and water coming up the esophagus generally will trigger, since the esophageal sphincter has to open up to let food and water come out. You know, let me go back here a couple slides. There we go. Yeah. There's the esophageal sphincter right here. When you vomit, food and water come up this way, Now, when that sphincter opens up, the epiglottis usually goes shut so that you don't aspirate at the same time you're vomiting. However, it's not a guarantee that you're going to, be able to vomit and not, inhale, particularly if your patient is asleep or unconscious. That's generally when you want to keep them turned on their side so that if they're going to vomit, they're not going to be laying on their back and vomit and then inhale. So, but generally, the esophageal sphincter will try very hard to protect us and keep that epiglottis closed. So, okay. Now, sound production. Vocal folds are in the larynx. We have what are known as the true vocal cords, and we have the false vocal cords. The false vocal cords are what we call the vestibular folds. They don't do anything. They're on the outside of the true vocal cords. The vocal cords are lined up on each side of the glottis, and they tend to be more white than pink in here. So they are the structures closest to the actual opening, and they vibrate, and the reason that they appear white, why the true vocal cords appear white is because they don't have a lot of blood vessels in there. Less blood vessels makes them appear white. The false vocal cords are highly vascularized, so they appear pink, or flesh colored or whatever. So okay, so we have the vocal folds, we have the false vocal folds, we have the opening of the glottis, and you can just see the trachea down in here. We open and shut the vocal cords, vocal folds to generate sounds. We make them vibrate, we stretch them, we raise our voice, we lower our voice, we make all sorts of funny sounds. And if we look at our model here, we can see there's the vocal folds, and here are the false vocal folds or vocal cords right here. So, because these are more vascularized than the vocal cords are. And I have that model. Let's don't want that one. Don't want that one. No. Okay, this is our model of our trachea right here. And you can see this is the epiglottis up here. Half of it's broken off. I don't know how. But if we take this apart, you can see where the vocal cords are located right here. These are the false vocal cords here because they're highly vascularized. The true cords are here. They're white. They're more white than the other one. If we take a look at if I put this back together and we look straight down into it, you get a real good representation of what they look like. If I would stop moving my hand around. How would I do this? There. Stop moving. Okay. The white bands inside there represent pretty well the location of the true vocal cords, and the thick pads on either side of them are the false cords. So this is not, it's not my favorite model, but we still use it. Okay, let me get back to this. Now, vocal cords, and now soundness. The sound that we make we speak because of the movement of air through the vocal cords. They vibrate. How much they vibrate depends on the tension we put in there. And then we use our mouth and our tongue and our teeth to shape the words that we create. Sound is controlled to a great extent by the hypoglossal nerve that comes down from the medulla and innervates the tongue. So the false chords have nothing to do in sound production. I made the point when we were talking about in endocrine, and I think I made the point in AP1 on bones. Individuals with acromegaly have enlarged mandibles and maxillas and nasal bones, and they have a very difficult time in speaking clearly because their mandible is so large, their maxilla is so large, their nasal bones are so large, their nasal cavity becomes so large, they end up having a very nasally, a deep nasally sound, if you will. It's sort of hard to imagine, but the way they speak is affected by the shape of their mouth. Even though their vocal cords are working fine, the shape of their mouth and their tongue and their teeth affect everything. So, okay. So here's what they look like when they move. You can see the vocal cords are vibrating. They're stretching in both cases. The second picture, the smaller one, gives you a real nice image of the epiglottis and the vocal cords opening up depending on what kind of sounds we're making. And you can even see the false vocal cords. You can see them better on the left side. But this is a real good image too. So this is what it looks like when we speak or when we're making sounds of some sort. Another thing that we encounter in our larynx is a pretty complicated structure. We have something called Valsalva's maneuver. Valsalva's maneuver. The vocal cords function as a sphincter. You know what a sphincter is? It's a ring of muscle to close off a passage of some sort. The vocal cords act as a sphincter to close the glottis so that we hold air in the lower respiratory tract, in the bronchi, in the bronchioles, in the lungs. And so when a person is straining to do something, we do Valsalva's maneuver all the time. You're going to pick up something really heavy and you have to strain to pick it up, okay? You stabilize your abdominal cavity. You close off your airway. You close off, you trap the air inside your lungs and in your trachea and your bronchi. That allows the pressure in the abdomen to rise when the rectus abdominis muscles contract, and we create a lot of inner abdominal pressure. It's also what stimulates the vagus nerve too. Valsalva's maneuver. This is why if you sneeze vigorously, you may see spots in front of your eyes. You may be a little dizzy for a second because you have closed off your airway and you have stopped breathing. You stop breathing when you sneeze or when you cough vigorously. You stimulate the vagus nerve. A little more acetylcholine got dumped into the heart, and maybe your field of vision dipped a little bit just for a second, and you were a little dizzy. So all because we're closing off the airway. So it's not enough to talk about, you know, the inner abdominal pressure rises because we are contracting the abdomen with our rectus abdominis. We got to have something to contract against, so we close off the airway. Now, this is also what we use when we're trying to empty our bowels. When you have a constipated patient, they're straining to force fecal matter out of their rectum. It is the same process of generating pressure in the inner abdominal, in the intra-abdominal cavity. In the abdominal cavity, we raise the pressure, we've closed off the airway, we're not taking a breath, and we're straining to empty our bowels. And this is same thing's happening there. The same thing that's happening when we pick up something heavy, or when we cough or sneeze, or when we're straining to empty our bowels. So, and we've all probably had laryngitis. True laryngitis is when the vocal cords are inflamed. You know, lots of people say they got laryngitis because they have a sore throat, and maybe they do. But true laryngitis is an inflammation of the vocal cords, and we sound very raspy and very hoarse when we talk. And so a person that says it comes up to you and says, "Hey, I've got laryngitis. I can't talk very well," just like that. Well, they may have a really bad sore throat, but they probably don't have laryngitis. So, okay. Now the trachea is about 4 inches long. This is a trachea right here. And let me just. This is the trachea from here to here. It's surrounded by rings of cartilage that are shaped like a letter D. They're round in the front and they are flat on the back side. This flat surface on the back side here is designed so the esophagus can run along in here where I've got the pencil. So our esophagus runs down here. But these rings of cartilage that you can see here are keeping our airway intact the whole time. So, and then the trachea then breaks to the primary and secondary bronchi a little further down. Let me get where I was. Okay. About 20 rings of cartilage. Because there are no cartilage on the back side, because it's a flat surface, we can allow the esophagus to expand as food goes down through there. The esophagus is normally a flat tube butted up against the trachea. The only time the esophagus is busy is when food's going through it. Now, the ends of the ring of the letter, looks like a C or a letter D, have the trachealis muscle. And the trachealis muscle is what we use to cough. So there's our larynx, there's our trachea, there's our right there, there's the rings of cartilage down to where they're going to break here at the branch at the bronchi. And again, same thing here. This is all the rings of cartilage, larynx, thyroid gland, yes, thank you, trachea, bronchus. Now, this is the ring. This is what it looks like if we're looking at it in a very unusual angle. But here is the front of the trachea. There's the lumen. This is a trachealis muscle right up in here. We use that when we cough to clear mucus and other stuff out of our airway. And then, of course, this is the esophagus from the back side right there. The trachea is lined with pseudostratified ciliated columnar epithelial cells. The cilia are in a layer of mucus, like we've said that many times. A person that smokes will destroy that cilia and will have a difficulty in getting that mucus up into their pharynx so they can swallow it. Usually what will happen is a person that smokes will have to cough every morning. We call it a smoker's cough. That's what a smoker's cough really is. It's the coughing to cough the mucus up to get the mucus out, that the cilia aren't working because they've been paralyzed by tobacco smoke. If a person stops smoking, the cilia recover. So, but as long as they're smoking, then they're going to be coughing every morning to cough up. They're not going to cough up a lung, but they're going to cough a lot of mucus up to get rid of all the crud that's accumulated because their cilia are simply inhibited. So, other things about the trachea. This is where the trachea is where we are very concerned about airway obstruction. People choke on food. They swallow something through the epiglottis, blocking the glottis, and it closes off their trachea and they can't breathe. The Heimlich maneuver was developed years ago by simply providing pressure against the abdomen to force the lungs to deflate and push air out the trachea to literally pop the object out. So the force, and you've all seen probably in movies or TV, or maybe know someone that's had it done. It has a pretty powerful, projection in here. So, okay. This is what our bronchi look like. The airway, the trachea now is going to branch 23 times to spread out. We call this the bronchial tree. We've probably all heard that term. We've heard of bronchitis, we've heard of bronchioles, we've heard of bronchi. The bronchi divide and divide and divide. They divide out 23 times. We have to go from the conducting zone down to the respiratory zone. And what that means, we have to get down to the level of the single squamous epithelial cells that form the alveoli. This is actually a pretty interesting phenomenon, interesting picture here. They took a cadaver's lungs and they filled every bronchi and bronchiole with latex. And that's what we're seeing here. A latex cast that was forced into every opening to show you that there really are these 23 branchings, because you've got millions of alveoli in each lung. So you got each alveoli is supplied by a respiratory bronchiole. So this is a blood clot shaped like a bronchial tree. This is an inadvertent cast made of part of the bronchi in an individual with lung cancer. And when a person is dying from lung cancer, the tumor is eroding away usually the pulmonary artery or the pulmonary veins, or maybe even the aorta. And so you get a lot of bleeding into the respiratory tract. And this person coughed up a tremendous amount of blood one day just before they died. Like this, they died about 2 days after this. And it came out, this clot came out in an almost perfect shape of a portion of the lower bronchi.
They coughed this out?
They coughed that out. So the phrase coughing up a lung actually means something, so. And you can see it, because, lung cancer in its final stages is really nasty, because your patient can't breathe. They're choking on their own blood. They're eroding away their own blood vessels. If they erode the aorta, then it's all over. But if they're eroding the vena cava or the pulmonary veins or something that's not under pressure, it takes a while to die. And so it's very painful too. So, okay, conducting zone down into the trachea, we go with the left and right primary bronchi. Then we have the secondary bronchi. The primary bronchi divide into left and right. The secondary bronchi go into the lobes of the lungs. Now they are the lungs, there are two lungs, left and right. The right lung has 3 lobes. The left lung has 2 lobes. The left lung is smaller, slightly smaller than the right, because it has to accommodate the heart. So we have here we can see, for example, here is a left lung. This is a left lung. It only has 2 lobes. Thank you very much. Well, you can see here on the illustration here, there's the left lung with 2 lobes. There's the right lung with 3 lobes. This indentation here that you see is for the heart. And so it would snug together something like you're going to see here on this right here. This is a left lung right here. I'll get your question in a second. This is the left lung, 2 lobes. There's the space for the heart snugs in here. So the 2 lobes are, I didn't mean to say it how I said it. The 2 lobes give you as much surface area as the 3 lobes do. You just have to have room for the heart because the heart is tilted off towards the right-hand side. Let me see what your comment was. Does the right lung injuries like a collapsed lung due to trauma more difficult to come back from than the left? Maybe. You know, I've never seen any data on it either way. It's possible that since that one side or the other is favored, you know, with the right lung having 3 lobes, is it going to have more trauma? I don't know. I've never seen anything on that. That's something I can look up to for you. So let's get back to this. Okay. Now let me go back. I think I got carried away with myself. There we go. Okay. Now the bronchi, you have the secondary bronchi give you to rise to the 2 lobes and the 3 lobes. And then we finally keep dividing until we get down to the bronchioles. They are less than 1 millimeter in size. And then we have the terminal bronchioles, which are 1/2 millimeter. So we're pretty far down into the lungs at that point. You know, we don't even see it here, but we're way down in the terminal bronchiole because there's the primary bronchi, and then the 3 lobes, the secondary bronchi there, and the 2 lobes here. And then we get down into the respiratory zone. The terminal bronchioles, the 1/2 millimeter in size terminal bronchioles become the respiratory bronchioles that lead into the alveolar ducts, and our alveoli form sacs. They look like clusters of grapes when they're the way they're attached here. They don't, the alveoli generally, the only place you would see alveoli individually is when they're on the respiratory bronchioles. Normally the alveoli hang together in clusters, and we have about 300 million alveoli in our lungs. So we have a lot of alveoli, and that's where gas exchange takes place. Here we see the terminal bronchiole leading to a respiratory bronchiole. We can identify a respiratory bronchiole because it will have alveoli popped up on it, individual alveoli. Then that will lead to an alveolar duct, and we have our clusters of alveoli here that, you know, if they were green or purple, they'd probably look like grapes. And again, now, these alveoli are all interconnected. They have pores that allow them to equalize air pressure. They are elastic. They are elastic so they can expand and contract very nicely for us. You know, they will inflate and they'll deflate. They're surrounded by smooth muscle. And so we try to maintain equal pressure in all the alveoli. So, and they are extraordinarily thin. They are 1/2 micrometer in thickness, which allows oxygen to diffuse across their membrane into the membrane of a capillary. And again, they're coated on the inside with water so that we can, the oxygen has to be dissolved in water to move across their membrane. When you have pneumonia, when your patient has pneumonia, for example, pneumonia causes an accumulation of mucus on the inside of the alveoli. And that increases the thickness of the what we call the respiratory membrane, making it more difficult for your patient to breathe because oxygen can only diffuse across a couple micrometers. And the increased thickness of the membrane by the added mucus from pneumonia. Makes it very difficult for your patient to be able to get enough oxygen. You know, dying from asphyxiation is what kills your patient that has pneumonia. So we got two types of cells here, type 1 and type 2. Most of our alveolar cells are type 1. They're the simple squamous epithelial, but we have a few types of type 2 alveolar cells. They're busy secreting something called surfactant and antimicrobial proteins. Surfactant is what keeps the alveoli from sticking together. Consider that they have the consistency, you know, of single-ply wet toilet paper. Now, single-ply wet toilet paper is much thicker than these alveoli, but consider how hard it is to try and expand, you know, 300 million bubbles made of single-ply wet toilet paper, you know, and keep it inflated and keep it from sticking together. The surfactant acts like a detergent and keeps the single layer of simple squamous epithelial cells from sticking to each other. So it'd be like if you could take a whole roll of single-ply wet toilet paper and create these bubbles with it and have it not stick together for you. It's impossible, you know. I've never tried it, but it's got to be impossible. So. Okay, I already mentioned that and mentioned that. So here's what it all looks like. You know, there's your terminal bronchial, there's your respiratory bronchial, there's an alveoli sticking up, and there's another one. There's our ducts, and now we have our clusters. But each alveoli is surrounded by 100, maybe up to 100 capillaries. So we have great gas exchange into the blood supply at each alveoli. Look at the cast there in latex of the capillaries. Those are the casts, you know, the alveoli were where these big holes are, but these are the capillaries that surround the alveoli. So you have a tremendous amount of blood exchange at each alveoli. So again, it's only one cell layer thick. You know, and again, we equalize the pressure. So there's our alveolar membrane, there's the capillary, there's the red cell. We don't want to go, you know, it's just thin enough for oxygen to go across the membrane. Okay. A couple other points, the pleura, that's the serous membrane that surrounds the lungs. We have each lung is surrounded by what's called the visceral pleura. It's a serous membrane, and the visceral pleura is covered by the parietal pleura. The parietal pleura sticks to the chest wall, on the inside of the chest wall, and in between the visceral and parietal pleura is the pleural cavity or pleural space, and it's filled with serous fluid. It acts like glue. And when the chest wall expands, the lungs expand with it. When the chest wall relaxes, the lungs relax. So when we raise our chest by contracting the external intercostal muscles, our ribs rise up and the lungs go with it. And when we deflate when we relax our ribs with the internal intercostals, the ribs go down, the chest goes down, and the lungs deflate and push air out. And so we keep the lungs covered with this serous fluid so there's no friction. We don't like friction at all. And so they don't rub against the chest wall, they rub up against the mucus layer, the serous fluid. So if the pleural membranes become inflamed, it's a condition known as pleurisy. The pleura become very rough. They don't have the serous fluid like they need. And every time your patient breathes, the pleura rub together. And it's like rubbing sandpaper on your hand. That's how it was described to me one time. And it hurts, excruciating pain, they say. You know, I would guess rubbing sharp sandpaper on your hand would probably be uncomfortable. It makes it can cause a problem in breathing too. So this doesn't happen very often, but it does happen. And okay, I mentioned all this already. We already know how the lungs are supplied with blood. The pulmonary arteries bring deoxygenated, lower in oxygen blood to the lungs, and then we reoxygenate them and send them back to the left atria and the pulmonary veins. And I already said all that already. So, and it is mostly, well, it has shared nervous control. The lungs are generated by both the sympathetic and parasympathetic nervous system. The parasympathetic fibers will allow bronchoconstriction to occur, and the sympathetic causes bronchodilation, because parasympathetic is going to cause bronchoconstriction by stimulating the release of acetylcholine, and sympathetic is going to release norepinephrine and epinephrine, and they're going to dilate. Which is why if you have a patient with asthma and they have a rescue inhaler, they're going to be using some sort of hormone in there like epinephrine or norepinephrine to open up their airway. So, okay. And let's see. One last point here. When the diaphragm, this is how we breathe. When the diaphragm contracts, when our diaphragm contracts, it drops. It drops down into the abdominal cavity. At the same time that happens, at the same time that our diaphragm drops, our external intercostal muscles contract and raise our ribs. Our lung volume increases. When our lung volume increases, the pressure inside the lungs drop. And that causes air, outside air, to get sucked in. So we contract our diaphragm, it drops down. I know it sounds counterintuitive. When it contracts, it drops down. So the thoracic cavity is getting bigger. The ribs rise. Thoracic cavity has gotten even bigger. Now the lungs have been dragged along with the chest wall. The pressure inside the lungs is now less than it was before. And what will happen is that air will rush in to the lungs because the air pressure is lower. Whenever air pressure drops, the lung volume will increase. I've got a neat little demonstration here to show you. I found the balloons. Yes. This is a vacuum chamber. Let me put this on the camera. If it doesn't work, I can fail in front of everybody. Okay. This is a vacuum chamber. There we go. It'll be a vacuum chamber when I put the top on. This is a balloon. We spared no expense. This is a high quality Walmart balloon. I dropped the balloon inside here. You notice it is lots of room inside here. Put the lid on. Good and tight. Now this is a pump. Notice the size of the balloon. Let me bring this down so you can see the balloon in here. And as I pump the air, I'm going to pump air out of here, reduce the pressure inside the chamber. Okay. Now, how big is the balloon now?
That was pretty cool.
So the balloon has expanded at least twice its normal size because I've sucked out the air from the chamber. I've lowered the pressure inside the chamber. That's what happens in our lungs when our lungs expand. When our lungs expand and when our diaphragm drops, the volume inside the lungs increases. the air pressure drops. Now, I couldn't expand the size of the chamber here. I just dropped the air pressure. And you saw the balloon decide to take advantage of that and expand. If I had an unlimited size chamber, I could probably get that balloon to inflate itself until it popped. So now if I lower the pressure, it goes back down to its original size. So this is, when we get into lecture, I'm going to talk about something called Boyle's Law, about pressure and volume. You know, as pressure, as volume decreases, pressure increases. Or as volume increases, pressure drops. This is how we breathe. We'll talk, I'll probably get to do this again in lecture. So anyway, this is, let's see, is there anything else I wanted to say on that? Nope. Okay. Then we are done with the respiratory system as far as the anatomy goes. So I got to play with a bunch of toys today. I'm really happy. So, okay. Anybody have any questions on anything? Okay, then I'm going to get us out of here, and I'll see you all next week.